Thank you. Hi, everyone. Thank you for a nice introduction. So I'm Erta. I'm a second-year PhD student in the brain physics lab. And today I'll talk to you about cerebral autoregulation in traumatic brain injury. First of all, why are we here at the Conference on Everything and we talk about traumatic brain injury? Well, because traumatic brain injury has a huge impact on our society. It's a leading cause of death and disability worldwide. However, the clinical management of these patients is quite challenging because of the heterogeneity of the population at risk of TBI, traumatic brain injury, and also because of the variations in injury patterns. Therefore, we need improved characterization and better understanding of pathophysiology in individual patients. In other words, we need precision medicine. Precision medicine has been investigated in several aspects or fields for traumatic brain injury, like genetics, blood biomarkers, or data integration. What we focus on is this, intensive care unit physiological monitoring, and in particular monitoring of cerebral autoregulation, which is my favorite curve from our physiology books. Let me take you through this plot so that we all understand how this works. So we have, on the x-axis here, you have cerebral perfusion pressure, which is the pressure that drives the blood flow through the cerebrovascular bed. Then you have, in black, cerebral blood flow. In red, you have the resistance, cerebrovascular resistance, and in blue, cerebral blood volume. These circles here are the vessels that can dilate and constrict actively. So how does this work? If the pressure is between this and this range here, so we call this lower limit of autoregulation and upper limit of autoregulation, then a drop in pressure would cause a vessel to dilate, the resistance would drop, and therefore the flow will be kept constant. However, if the pressure drops below this limit here, a drop in pressure would cause a drop in flow. The brain would be at risk of ischemia. On this other side here, if the pressure increases above the upper limit, an increase in pressure would cause an increase in blood flow. The brain would be at risk of hyperemia. None of these two outside the autoregulatory range are good for our brain. Now, in traumatic brain injury patients, this mechanism is impaired, and this white plateau here may be narrower or shifted, or we can have a relationship that looks like this. Now, why is this important? Because if this is the relationship between pressure and flow, then any change in pressure is directly transmitted in changes in flow, and the brain is deprived by its protective mechanism. How can we measure this? How can we monitor this? I told you about the active vessels changes in diameter. These are reflected into changes in blood volume, which are then transmitted into changes in intracranial pressure according to the pressure volume curve of the brain. Now, if we assume that the variability in intracranial pressure is entirely driven by variability of extracranial blood pressure, then by measuring how these slow vasogenic waves are transmitted into waves from ABP, arterial blood pressure, in intracranial pressure, then we have a measurement of cerebrovascular activity. This correlation between the two slow waves is called pressure activity index. If the correlation is is negative, you have good autoregulation. But look at this case here. The waves in ABP are directly transmitted into waves in ICP. The correlation is positive, impaired autoregulation. PRX, the pressure activity index, is a measurement of global autoregulation and statistically agrees with outcome. But more interestingly, if it's plotted against values of cerebral perfusion pressure, it usually shows this U-shaped curve. The optimum of the curve identifies a value of CPP at which PRX is more negative, cerebral autoregulation is best preserved. We call this value optimal cerebral perfusion pressure, or CPP. Large retrospective studies have shown that if CPP was close to CPP opt, the outcome was better in TBI patients, but if CPP dropped much below or was much higher than CPP opt, the outcome was worse. Therefore, CPP opt was suggested as a dynamic, individualized CPP target for traumatic brain injury patients in order to keep the brain in the middle of this plateau. The brain would be protected. Now let's go back at our intensive care unit. We have a traumatic brain injury patient here, and we have the possibility, thanks to neuromonitoring software, this in particular has been developed in my lab, SM+ software, we can retrieve high-resolution waveform level data from bedside monitors, apply the advanced signal processing techniques, and obtain a time trend of CPP opt and display it at the bedside. This offers the opportunity to clinicians to target CPP at CPP opt. And we just published a feasibility study showing that this approach is safe and feasible in traumatic brain injury patients. But CPP opt is not the whole story. Remember the U-shaped curve that describes the relationship between the index of autoregulation and CPP. If we assign a threshold for high values of the index of autoregulation above which autoregulation is completely lost, then we can identify values of CPP at the lower limit of autoregulation. And we can track them in time as well. Look at the second plot here. We have a pressure time chart. In yellow, you have the real cerebral perfusion pressure of the patient. And in orange, our estimation, continuous estimation of the lower limit of autoregulation. Now what happens here? Cerebral perfusion pressure is above the lower limit, the brain is protected. But in this case here, perfusion pressure was below the lower limit of autoregulation, and this event was unnoticed because we didn't have the continuous monitoring. And as you can see, the lower limit is quite dynamic as well. So let's summarize this story. We have a physiological mechanism called cerebral autoregulation. We can monitor this in TBI with PRX. We have the opportunity to optimize the cerebral perfusion pressure in order to optimize autoregulation. We show that this approach is safe and feasible, and we also have the possibility to monitor the lower limit of autoregulation. But clinicians just published a consensus that said that actually consensus could not be reached on the accuracy and reliability on this approach. So at this point, we must step back and ask ourselves, which are the reasons for this lack of accuracy and reliability? And this is exactly what we'll do in the next part of this talk. We'll go back step by step, and we ask ourselves those questions, starting from the lower limit of autoregulation. I just showed you this plot here, pressure time chart, lower limit of autoregulation in orange, and I told you, well, if we have LLA displayed in time, we can avoid these events here. But this is an estimation of average LLA. And as you can see, in traumatic brain injury, at the same time, in different parts of the brain, we have different biochemical storms. So what I mean by this is that, for example, in this case here, we can assume that in this part, autoregulation is impaired. We have a positive correlation. But in this part here, autoregulation might still be preserved. So at the same time, some vessels are dilating, some vessels are restricting. What we measure, though, it's a reaction to the global average variation in volume. And how about CPP opt? This is how a pressure time chart with a CPP opt time trend looks like. This is a pretty one. But sometimes the result of our mathematical algorithm that is running at the software at the bedside gives this sort of result, which is not physiological. This is erratic behavior. It's mathematically correct, but it doesn't reflect physiology. And also, we don't know how confident are we at each time point when we provide these values. And how about our measurement of autoregulation? I told you that we describe how changes in ABP are directly transmitted into changes in ICP. But this assumes that there is a causality between the two. And every change that we measure here is directly related to changes that we measure here. We also assume that the transmission is always reliable. Remember that this depends on the pressure volume curve or compliance curve of the brain. These assumptions need to be met and verified before giving indexes based on this one. And how about our cerebral autoregulation physiology? Well, in the beginning, I showed you this curve, and I told you this is my favorite physiological curve. And I showed you that there is this wide plateau range where autoregulation is preserved, meaning where changes in cerebral perfusion pressure are not directly transmitted into changes in cerebral blood flow. The wide plateau here derives from the first study published on this matter by Lassen in 1959, where he could draw a wide flat range, a wide plateau, because he averaged values different experiments coming from humans with different pathologies. However, recent publications show that actually we might not actually have a plateau, but what we have is a range where changes in ABP are not directly transmitted in blood flow. As you can see, it's much narrower and it's not a plateau at all. So at this point of the story, I hope you are confused, at least as much as I am. But don't worry, because I identified the next chapters of my PhD, and this is what I'm going to address in the coming 2 years and a half. Thank you all for your attention. I would like to thank my brain physics lab, in particular my supervisor, Peter, my funding bodies, MRC and Gates, and Churchill College for their support.
Thank you very much for the talk. I think most of us have been in the situation when you realize that, there are so many other questions to answer that I caused for myself. But I'm looking at the audience at the moment, if anyone has any questions. I'm looking around. Yes, coming.
So, what are these other questions that you're going to be looking at in the next 3 years?
Okay. I'll go back to one slide. Okay, so the first thing I want to look at is if we have a better way of characterizing the relationship between the waves, the slow waves in arterial blood pressure and intracranial pressure. And for that, I identified signal processing techniques and deep learning methods. The second thing I want to do is to see if we can identify the physiological and time variability of autoregulation in TBI. It changes over time, but we don't know until what point. And then I want to develop a tool that could provide a quality or uncertainty measurement on the indices that we provide, so that we tell the clinician, look, this is what I think your CPP should be, but I'm not that confident, so that the clinician can make an informed decision. Or this is what I think it should be, and I'm really confident about that. Some sort of confidence interval or Bayesian inference, whatever will be. And finally, I want to identify the relevant aspects of bedside application of CA in TBI. There are some things that can influence cerebral autoregulation in TBI and that can be managed at the bedside. But what we don't know at the moment is what is the relevant mechanism at that specific time point for that specific patient.
Wonderful, thank you.
I hope I replied.
Hi, so you mentioned a couple slides back, I don't know all the terms, there was a number that you estimated based on the average, which is not necessarily representative, especially if the brain is injured. So in that case, do you then optimize for the average, or can you actually administer interventions in a way that is targeted to the different parts of the brain differently, if you do know that?
This is a very good question, thank you so much. The issue that we have at the moment is that we estimate the average, and all we can do is to optimize the average, because the perfusion pressure comes from one direction. It's a systemic blood pressure that goes up and intracranial pressure that pulls down, and therefore you calculate the cerebral perfusion pressure. However, what I want to do is to try to identify if we have something in the signals that can, by signals I mean the waveforms of ABP and ICP, that can tell us how diffuse this mechanism is. Unfortunately, if you want to have a high time resolution, you miss completely the high space resolution. So we will not, at least I don't see it feasible at this point to have some sort of space resolution in what we do. There are non-invasive methods that have been applied for this approach, but all we can do is bilateral, so one side versus the other. But as you could see, the problem is much more complicated than that.
Thank you very much. The time is up with that.